How are you guys doing? My name is Ian Schrock, and this is my Case Connections Unit 4 presentation. I chose to do Case Connections 2 and 3, so we're going to go ahead and get started. The intro to Case 2, you are presented with a 4-day-old infant who we are known to as Patient A. And we start to follow her in our clinic. Everything is normal about her birth, including birth weight and the actual delivery. Everything's normal. But a newborn screening showed that blood levels of phenylalanine were higher than the normal range, which is normally 1 to 2 milligrams per deciliter, but we got 6.6 milligrams per deciliter, which is about 3 times higher than the normal levels. So something's going on here with phenylalanine. Our clinic made a presumptive diagnosis of phenylketonuria, and then we get further analysis for the patient. And it is important to note that the parents deny a family history of PKU, which is another way to write phenylketonuria. First, we should talk a little bit about what phenylketonuria is. It's marked by elevated level of phenylalanine, which we did see it was 3 times higher than normal levels. PKU is autosomally recessive, so that explains why the parents did not have any kind of family history of phenylketonuria, because it does require that both of the recessive alleles be present in the individual. Classical PKU is characterized by low levels of phenylalanine hydroxylase, which helps convert phenylalanine into tyrosine. And it basically causes the reduced metabolism one way or another of phenylalanine, which causes it to increase levels in the blood, which is very toxic, especially once you get involved with the blood-brain barrier. It leads to seizures, mental disorders, behavioral issues, intellectual disabilities, and physical characteristics like microencephaly. So, as I mentioned, that phenylalanine hydroxylase that you have this issue with, or could have this issue with classical PKU, you can't metabolize phenylalanine and turn it into tyrosine, so that means that tyrosine, which is normally a conditionally essential amino acid, then becomes an essential amino acid, since the one way that we synthesize it biologically in our own bodies is from phenylalanine. So we have to get most of our tyrosine from our diet then. One thing to note about tyrosine is it's really important for forming epinephrine, melanin, dopamine, norepinephrine, and we also know that you can synthesize it into acetyl-CoA, as we learned this unit. As I mentioned, classical PKU, what I mean by that is the problem is inherently in the phenylalanine hydroxylase enzyme, which is the main enzyme that's responsible for turning phenylalanine into tyrosine. But as you can see here, we have tetrahydrobiopterin and dihydrobiopterin, which are also involved in the pathway. Tetrahydrobiopterin is an important cofactor of the enzyme, so you can actually have problems with this enzyme. What you can have is a biosynthetic deficiency, or in the physical structure itself, in the genetic code that you use to form that protein, you could have issues there. But the classic type is right here with the phenylalanine hydroxylase enzyme. Type 2 and 3 are effects of dihydrobiopterin reductase, which reduces it to tetrahydrobiopterin. This involves NADPH and transfers it to NADP because it reduces the dihydrobiopterin. Or you could actually have a problem with the dihydrobiopterin synthesis, which is important for forming tetrahydrobiopterin, which, as I mentioned earlier, is a cofactor in the enzyme. All of this leads to decreased metabolization of phenylalanine into tyrosine, leaving increased levels of phenylalanine into the blood. Now, because we do have this tetrahydrobiopterin deficiency or some type of biosynthetic deficiency or an actual functional deficiency, one potential cause or ability for treatment could actually be to supplement tetrahydrobiopterin if the actual phenylalanine hydroxylase enzyme is okay. And that's a BH4 loading test. There was another patient, patient B, who was similar, and they also came up with a similar diagnosis, and they did a BH4 loading test for both of the patients. But as you can see, with patient B, it responded much better to the BH4 loading test, and the phenylalanine concentrations dropped dramatically. But with patient A, nothing happened. It just continued to increase, which means that patient A is not BH4 sensitive. So that means that patient A probably has classical PKU, meaning that the reason, if you go back to the previous slide, is actually with this core enzyme here, phenylalanine hydroxylase, which turns it into tyrosine there. Whereas patient B likely has an issue with tetrahydrobiopterin, either with the biosynthesis or the actual form. Moving on to case 3, we have a gout situation. It's a 47-year-old man who presents with severe pain in his right great toe. He's unable to bear weight on his right foot, and there's no apparent trauma. The pain started the previous night and continued to increase in severity, so continually getting worse. Basically, the clinical findings suggest gout. Gout has several different mechanisms, and so they drew blood and they did a urinalysis, and here are the results. As you can see, normal range for plasma urate is less than 7 milligrams per milliliter, and the normal urinary uric acid levels are 413 milligrams in 24 hours. So there's a couple different ways that we can increase uric acid in the plasma, which then gets into the joints and forms crystals. That's essentially what gout is. Every once in a while in my orthopedic clinic, we do see it in knees and such, but the classic gout is that big toe gout. So with uric acid, we have a few different, as it's important to notice, this patient has increased plasma urate, but it has decreased urinary uric acid. So there's a couple ways that we could go about figuring out this patient's issue. One is overproduction of purines, okay? Now, overproduction of purines, as we know, metabolizes down to uric acid. What that would leave you with is an increased plasma urate and potential for these uric acid crystals to form, but because normal urinary uric acid is 413 milligrams for 24 hours, there's nothing to suggest that this won't actually increase when you actually increase the amount of plasma urate. It's the same thing as if you were to normally filter out a certain amount of vitamins, but you take a supplement and now all of a sudden your urine has a lot more of this vitamin in it. There's no reason to suggest that the kidneys would not be able to, in normal healthy kidneys, handle this increase in plasma urate, at least for the time being. That would not explain why this patient has a decreased level of uric acid. So while that is possible for gout, that's not probably what we're dealing with this patient. Another option is the decreased salvage of purines, which would be, instead of sending it the whole way through to uric acid, you could salvage some back through into the system. And again, that would cause for an increase of urate to come up, but nothing wrong with healthy kidneys. It should still be able to handle this increase in plasma urate and filter out simply more of it. So as you can see, it's plus or minus 78 milligrams per 24 hours is normal, but that doesn't mean the kidneys are not actually capable of doing even more than that. So again, plasma urate still checks out, but urinary uric acid doesn't make sense. The last option is decreased urinary excretion of uric acid. And that seems to be the best option because we really do have decreased excretion. This is measurable, quantifiable. We can see it here in the data. And what that leaves you with then is an increased level of plasma urate because you're not excreting enough, and that's what forms the crystals. And that's what it seems like is fairly evident with this patient. Now, another thing, further discussing the patient, he says he switched from diet to regular, and he drinks between 4 and 5 liters of soda a day, which is a lot of soda, main ingredient being fructose. So how can fructose affect gout, and what should we tell the patient? Well, it's important to know that fructose actually causes increased uric acid levels. So with this patient who has kidney problems and he's not filtering out enough and removing enough uric acid, this is going to completely exacerbate the problem because not only does he have a filtering issue, but we're continually pumping more and more in because of this fructose pathway. Fructose, when it breaks down to fructose 1-phosphate, you utilize ATP to ADP, which then gets further broken down to AMP, which is then, as we know, through this pathway, and xanthine, hypoxanthine, turned into uric acid. That's the uric acid pathway. And this is just going to create more uric acid. So as you can see with this diagram here, more dietary fructose equals more uric acid production. So we should probably tell the patient to lay off of the soda. And here are the sources. Now, it is important to note that there is actually a study that shows that dietary fructose does actually increase uric acid concentrations in males. So that would definitely worsen this patient's gout. All right, thank you.